Good afternoon, everyone, and welcome to the Health Equity Speaker Seminar. I am Marie O'Neill. I'm in the Epidemiology and Environmental Health Sciences Department here at the School of Public Health. And I would like to acknowledge Amy Schultz and Ilana Lebron, who's a doctoral candidate in health behavior, health education, and Amy's a faculty member there. They are the co-organizers of this seminar series. And our goal is to feature groundbreaking work from around the globe to address issues of equity and health. And so we're very excited to be offering this series for our fourth year. So this series would not be possible without support from a number of people and units. And so we wanted to thank the Department of Health Behavior and Health Education, the Center for Research on Ethnicity, Cultural, and Health, the HBHE doctoral student group, and we also want to thank the Faculty Allies Program at the Rackham School of Graduate Studies and the Office of the Dean here at the School of Public Health for their financial support for this series. And I don't think I've left maybe the Center for Social Epi and Population Health. But last but not least, we want to thank Denise Fortune, who has been amazing in setting up the speaker series and providing logistical support. So before turning this over to Ilana, who will be introducing our speaker today, I want to point out that on all your tables are small evaluation forms, and I'd like you to take a moment before you leave to fill those out and place them in this lovely pink envelope, because the feedback that you give us helps us maintain a high quality and relevant speaker series. So thank you again for coming, and I now turn it over to Ilana to introduce our speaker. Thank you.
Good afternoon, everyone. It is my pleasure to introduce my colleague, Diego Lucumi, who received his medical degree from the Universidad del Bosque in Bogotá and earned his master's degree in public health from the Universidad del Valle in Cali in Colombia. In 2014, he received his doctoral degree from the Health Behavior and Health Education Department at the School of Public Health at the University of Michigan. And currently, he's with the School of Social Sciences in the Universidad de los Andes in Bogotá, Colombia, where he's the coordinator of the research program in health behavior and health education, and also teaches undergrad and graduate courses in the Department of Psychology at this university. Dr. Lucumi's research interests include cardiovascular health and prevention, the social determinants of health, and health disparities. Please join me in welcoming Diego Lucumi.
Thanks for this generous introduction. I'm really happy to be here again. Before I was here as a doctoral student, and now I'm happy to present some of the work we are doing that began when I was here as a doctoral student. So I'm speaking on behalf of the Interethnic Coalition for Integral Health. That is the kind of a structure we created for doing the work we are doing during these 2-3 years. So let's start with some of the context. Before that, I want to say thanks, Amy, and all the people here for the invitation. It's really a great opportunity to share with you these activities and this work, but also maybe to get some feedback from you about the work we are doing. So for the presentation, basically, I want to talk about 5 topics. Initially, I want to present some context of Colombia and Quibdo, that is the city where we are working. Some antecedents for this work, and basically I will focus on the creation of the coalition and the activities this coalition is doing in that city. And finally, I want to share some of the lessons we have learned and some of the challenges we have identified and the conclusions of this work. So let me start with some context about Colombia. Colombia is a country in South America with a population that is 46, 47 million. It's a middle income country that is divided in 32 departments that in some way are similar to US states, and a capital district, or that is the capital district of the country. According to the last census in 2005, 11% of the population of Colombia self-identified as a Black or Afro-Colombian population, and 3% self-identified as indigenous, and the rest of the populations didn't choose any ethnic or racial category. It's important to say that behind Brazil and the US, Colombia has the third largest Afro-descendant population. Similar to other countries in Latin America, cardiovascular disease is the leading cause of mortality in the country. Despite the important role of hypertension for cardiovascular disease, the social patterning of hypertension has been under study in Colombia. So, as part of my dissertation, my doctoral dissertation, I tried to examine the social patterning of hypertension in the country. So basically, this table shows some of the findings I found in this part of my dissertation. You can see that there are, in general, differences between men and women in the social patterning of hypertension. For race and ethnicity, only I found a statistical significant association for Black women. Education, I found a gradient for men and women, but for men it's only statistically significant for those that have less than elementary education. For women was significant in comparison with men with high school or more than high school. And for women, you can see the gradient, but also was significant for all the categories. Physical capital was only significant for women, and the only variable that was similar for men and women was home ownership. This graph shows that education is a very important aspect in terms of hypertension in Colombia for all groups, but it's particularly important for Black women with less than primary education. So these are a preliminary analysis I did for supporting a grant proposal. Basically, you see that the overall prevalence of hypertension in Colombia, that is 25%. For those that this was the first study. These results are based on the first national survey that collected objective data about blood pressure in Colombia in 2007. So we don't have previous studies to compare, but for those people that had criteria to be considered hypertensive, only 36% know that they were hypertensive. So that is a very serious problem, but it's unfortunately similar to other countries, middle and low income countries. For those that were aware about their conditions, I think that was a very good prevalence that were treated. but you see the control, the level of control is very low. That is very another serious problem. So let me say something about the context of Quibdo. Quibdo is the capital city of the department of Chocó in the west of the country. The population is above 100,000, and unlike Colombia, most of the population of Quibdo is Afro-Colombian. 92% of the population self-identified as black. And the net basic needs index of the Quibdo is almost 90%. For Colombia, is 30%. So it's a big, huge difference in comparison with Colombia. Other important situation or circumstance in Quibdo is that the index of the reception of displaced population is 20%. That means that the total population of the city, almost more than 20%, represent people that came to the city because they displaced. So that is a very serious problem in the context of Quibdo, because the local government had to provide services for an important amount of people that is coming because they displaced. Only there are 3 cities in Colombia with these similar circumstances, and Quibdo is one of these cities. We don't know the prevalence of hypertension in Quibdo, but based on the national survey in 2007, the prevalence of hypertension in the Pacific Coast subregion was, that is the subregion in which is located Chocó, was almost 40%, and the prevalence of hypertension in Chocó, in the department of Chocó, is almost 40%. So we can assume that the prevalence of hypertension in Quibdo is around 40%. But we have some information about mortality. Coronary heart disease and stroke are the leading cause of mortality in population of age 45 years and over in Quibdo. So hypertension is an important condition in Quibdo based on this information. This is a similar graph for Chocó in terms of the prevalence of the overall prevalence of hypertension, but also the prevalence of awareness, treatment, and control. You can see that the prevalence of hypertension, the overall prevalence, is higher than for Colombia, that is 25%. But the prevalence of awareness, treatment, and control is a little bit lower than for Colombia. But in general, the problem of awareness, treatment, and control is similar across the country. So, taking these contents in consideration, in this presentation I'm going to show the work we have been doing in Quibdo since 2012, when I conducted a qualitative study as a part of my doctoral dissertation, until work we are doing now, that is basically we are doing research to support the designing of a pilot program for addressing some risk factors for hypertension. So let me start with some background about the qualitative analysis or study as a part of my dissertation in Quibdo. So you know that there are growing evidence about the role of the social and physical context in shaping the risks and disparities in hypertension. Research in the US context shows that, for example, neighborhoods play a very important role in hypertension. Unfortunately, we don't know the same kind of research in the Colombian context. But in terms of these factors, we also know that the decision about the conditions in which people live are influenced by the decision that social and political actors make. So the this research, the goal of this research was to try to examine how, in the frames of these social and political actors, or the role or living condition in the way these social and political actors frame hypertension risk and disparities. So I conducted a qualitative study because the qualitative approach makes a unique contribution to try to examine this kind of question, or to try to answer this kind of questions. So this was a sample of this qualitative work. Most of the participants were community leaders, but also I interviewed appointed municipal officials, policymakers, and health practitioners. And the sample was in general homogeneous in terms of the participation of men and women. I conducted framework analysis. That is a kind of analysis that is particularly used in public policy research. And I conducted 3 rounds of interviews in 2012. Framework analysis has 5 steps, beginning with familiarizations, including the identification of categories, then the indexing process, charting, and finally mapping and interpretation of the findings. So I'm going to present some of the findings that are important that for this presentation. I used the frame theory for guiding this study. So framing theory includes or 3 kind of tasks: the diagnostic, prognostic, and actors tasks. So basically, in terms of the diagnostic, one important finding based on the comments of participants is that the city is divided in 2 areas: the center of the center and the periphery. It's important to say that it's difficult to, or participants didn't mention specific geographic boundaries in the separation of this area, but in the social map they propose, there are these 2 areas. But also they identify similarities in some of the characteristics of the city. The central area is close to the Tato River, that was for many years the main means of the way people from Quibdo can communicate with the rest of the country. So the periphery is far away from the Tato River. So most of the public institutions are in the first street of the city. So the first street of the city is in the border of the Tato River, and you can see all of the businesses, banks, and close to the river. So this graph tries to summarize it's a kind of summary of the findings based on the participants' comments. In general, what participants mentioned is that in terms of the recent disparity of hypertension, there are some kind of municipal level determinants, basically 3 important aspects: the level of unemployment. Actually, Quibdo is the city with the highest level of unemployment in the country, almost double of the level of unemployment in Colombia. For displacement, that is a very important issue that in this city in particular, and the unplanned urban space. These are determinants influence or worse through processes of marginalization and stratifications to influence urban living conditions in that city. That in turn shapes factors in terms of availability, accessibility, and acceptability that also have an important impact on the traditional or risk factor for hypertension. So I want to share with you some of the some videos and pictures that shows some of the urban conditions people experience in Quibdo. No. Let me see. You can see here. Yeah. You can see that this was recorded at midday. You can see a lot of motorcycles. I think Quibdo is the city with the most relative most number of motorcycles in the country. What explains that circumstances is that in Colombia, particularly Quibdo, motorcycles are the means of transport. Replace the other kind of option for transport. And is one of the people that is working or is doing this kind of job is the only option people find for having some earning every day. So it's the only option people have in some cases. But you know the kind of problem that situation generate in the city, because you can see that you saw the pedestrian, how difficult it is to walk in the city, and the level of noise. Unfortunately, it was not possible to recent, but it's very high, the exposure to noise in the downtown in particular. If you try to walk in Quibdo between 7:30 and 8:30, and then at midday, and then between 5:30 and 6:30, it's almost impossible in some areas. It's almost impossible because the amount of motorcycles that are in the street, and also in the sidewalks. Every part of the downtown has this level of motorcycles. So that is a very big issue in terms of the causes of the problem, but also what this solution generates in terms of risk factor for hypertension. Other problem is show this picture because the other problem is the infrastructure. This is one of the sidewalks. It's very common to find this kind of sidewalks in the city. So walking is not, if you can't to walk because the motorcycle, then what is the alternative in terms of the sidewalk? So you have to compete with the motorcycles with the for the space. But also the food environment. This is the downtown. It's a very formal market. The city has the formal market, but this is very informal market that I think is larger. It's larger than the formal market. But you can see that all of the issues that this video has in the condition of how people sell products, but also the kind of space where because it is on the street. People occupy many streets on the downtown for selling these products. Okay. So basically, people in the interviews suggest some kind of structural policies and some more specific interventions for addressing all of these issues related to hypertension. And they mentioned that the participants may be, or the more relevant actors to be involved in addressing hypertension should be the local government and the national government. So here, people in general have a clear understanding of social determinants of hypertension, and they mentioned the key role of public policies in addressing these issues. And something that was important was that they requested to translate the findings of this study into the actions. So based on that, my work was to try to find funding for doing this kind of work and for translating the findings to actions. I applied for a funding and work with the local university, that is a public university, it's the only public university in the Department of Foucault. And after a process of identification of organizations and institutions, we established a local coalition with 9 community organizations, 2 government institutions, and the academia, the university in this case. Then the coalitions established the operating rules, and finally, one of the goals of this second phase of the process was to, because the first part was the qualitative study, the second phase was this work with the coalition. So one of the goals was to develop an overall plan, action plan for addressing hypertension in Quibdo. So these were the institutions and organizations that agreed to participate in the coalitions that translate the name of the coalition is in English is Interethnic Coalition for Integral Health. At that time, I was a doctoral student, so I participated in that conditions and also with the support of the professor schools. One of the activities that the coalitions, first activities after defining their operating rules, that the coalitions agreed was to conduct a workshop in order to have a common understanding of social determinant of hypertension. So we were working for in a 2 days workshop in order to try to create this common understanding and try to identify the key issues for addressing hypertension in the city. This is a picture of the workshop and also the material we create for doing this work that in particular was very helpful in order to guide the kind of question or kind of discussion we have during these 2 days. One of the results of this workshop was to create a model, the model that coalitions consider how to guide the work on hypertension. Basically, it's a tree. In the bottom, you can see the structural factors, and in the top, the consequences and also the more proximal factors. So that is the model that guides the coalition works in Quibdo. So the other goal was to, based on this workshop, to try to develop an action plan for addressing hypertension from the perspective of the social determinants of health. It was considered the first tangible product of the coalition. So the coalition was working for almost 3 months to create this document that is the action plan for promotion of cardiovascular health and the prevention and control of hypertension in the city. So basically this action plan has a structure we call 3 by 3 by 3 by 3 that has 3 goals in terms of equity, prevention and control, 3 types of actions, research, intervention and training, 3 kind of members or actors, community, government and academia, and 3 approaches, social determinant of health, participatory approaches, and life costs. These approaches are important in terms of because help to answer some questions. For example, community-based participatory research as it is used to answer questions about how and who, life costs to answer questions about when, in which moment of the life we have to intervene, and the social determinant of health is used for answering questions about what and why. And the action also, the plan also defined some kind of milestones for a 7-year period. That initially, after the creation of the coalition, the idea is to work on the diagnostic, on the community diagnostic, to try to have the action plans enacted and try to get the resources for implementation. Then the next step is implementation and processing process and impact evaluation, and then the outcome evaluation. Also, the Action Coalition developed this framework that is used for defining the kind of intervention that the coalition are interested in. Basically, consider 4 environments and 3 different factors that we need to consider with strategies and multi-level approach. So based on this framework, now we are working in develop a pilot program to increase healthy daily practices in physical activity and food consumption in Quibdo. So for this pilot program, there are some justifications. One of them is the relative absence of local intervention for addressing risk factor for hypertension, lack of theory and evidence-based interventions, and lack of evaluation of the few interventions that are in the context of people. So the pilot program has 3 phases: formative research, that is the research we are doing now, designing and implementation and process evaluation. For the formative research, we are using an ecological approach. We are interested in examining individual, interpersonal, and community factors related with physical activity and food consumption in the city. And we are conducting a qualitative study using focus groups, semi-structural interviews, and photo voice. And based on the qualitative research that was conducted before, we decided to, in the coalition, we decided to work in 2 neighborhoods in the center of the city and 2 neighborhoods in the periphery. So try to identify differences between these factors between both kind of neighborhoods, and also commonalities in factors that influence physical activity and food consumption in the city as a whole. So I just want to finish with some of the lessons we have learned so far. One is that we need to use a flexible approaches for working with community and institutional organization in the context like Quibdo. The other important aspect is to recognize particular dynamics of participation and involvement. Initially, we have 12 organizations, but now regularly we work with 5 or 6 of these initial organizations. So that is one of the big challenges, how to find the way to maintain the participation of this kind of organization. One of the explanations is that these people in the organization had to find had to survive. Usually people don't have time for be involved regularly in this kind of effort. So we are trying to use some alternatives of some approaches for maintaining participation, sometimes individual consultation instead of a big meeting. We try to establish a dialogue with organization by organization, but it's something difficult even if you use this kind of approach. But something that is important is that the role of the university as to maintain that kind of effort in the city. And also, we learned that we need to adopt a step-by-step process to articulate people in a small project, because for funding reasons, but also for the capacity for doing bigger projects. And also to take advantage of every opportunity we have to learn and teach and to create capacity. There are very important challenges in Colombia, but also in the context of Quibdo. One is the traditional approach that privileges individual and biomedical research instead of approach for social determinant research. That is a very key issue. The other is that there is a persisting idea of race and a biological marker. So some explanation for the differences in hypertension is because people in these cities are black, and black is a marker of the genetic issue that also increase the risk for hypertension. So that is very important. Actually, this Monday, one colleague called me because she was sitting in a meeting with one of the top person in the Ministry of Health, and the Ministry of Health is working on a national plan for preventing chronic disease in Colombia. And one of the key issues they use for explaining the condition of hypertension in the country is because genetic factors play an important role. So that is a very key aspect we need to consider in terms of doing this work. Because also these kind of friends influence the funding decisions about the projects that that are conducted in the country for prevention. We need more training people in public health. In Quito, there are few people with training in public health. Actually, just only 1 or 2 person have a master's degree in public health, so it's very limited. The amount of people with the training that we need for doing this kind of work. And also, for example, the local Department of Health only have 5 persons for addressing all of the problems that simultaneously have the city. So you can see the level of work these 5 people had to do every day. There are other pressing public health and social problems, the multiple commitments of the coalition members, and lack of research traditions and limited local evidence. And also we need to gain more attention at the local level, at the national level, but also at the international level. So finally, based on this work, we know that it is possible to move the discussion to the social determinants, but it's not easy work. It's a very complex work. It's feasible, but not easy. So we need to adopt a long-term perspective for doing this kind of work. We need to think to have a broad perspective, but work every day in small actions. And we need to recognize the multiple dynamics and challenges that cities like Quibdo faces in many aspects. We need to make a careful examination of resources and opportunities for doing this kind of work. Hypertension is not an important issue in the public and political agenda in general in the country. So that is one of the priorities if we want to change the current trends of hypertension in the country, but also in Quibdo. We are convinced that the local partnerships can contribute to reduce the gaps in terms of research, but also in terms of the policy intervention and the different kinds of intervention we need to do for addressing this problem. These are the members of the coalition, representatives of the different organizations that created the local coalitions. So I have to say thank you.
So we have time for some question and answers. So if you have a question for Dr. Lucumi, please raise your hand.
Hi, Dr. Lucumi. This is a really fascinating, very interesting talk today, so I really appreciate it because I haven't been exposed to personally or heard too much about research or projects related with the social determinants of health on more of a global scale, so I really do appreciate that. One thing I wanted to ask you a little bit more about was this issue with displacement. Now, I'm not too familiar with maybe the causes as to why people are displaced, who is being displaced when, and how long this is happening, and how that might potentially also be a risk factor or increased risk of certain relations with hypertension. So, do you have anything to say about that?
Thank you. Displacement is a key issue in general in Colombia. The country has been experiencing internal conflict for almost 60 years. But now, what we can see in terms of the causes of displacement is that the main cause is the conflict, the internal conflict. People from rural areas move to urban areas. So most of the area of Chocó is rural. Quibdo is the biggest urban area. So people try to move to the safe place, safe in some way. Because what happens sometimes is that the conflict move also to the urban areas. The conditions in some, the level of violence in Quito right now is very high. But the other reasons for displacement behind or related with the conflict are economic reasons. Quibdo is a very complex area because it's one of the biodiverse area in the world. But at the same time, it's rich in gold and other kind of minerals. So what happened, and in the north of the department, is a very appropriate land for some agricultural plantations. So what happened is that the idea is to displace people in order to take these lands or to apply to that for mining reasons. There are many situations that explain displacement, in particular in Quito, in Chocó. So some studies show that displacement has color and gender. Most of the displaced population is black, because usually are the population that is located in these areas, and most of the people that are displaced are women. So this gender is issue, is a race issue. So that is a very complex situation. Colombia, in relative terms, is the second country with displacement in the world, and in absolute terms, is the second, and is the 5 in relative.
I just have the numbers for displacement. It just was released. I forgot who the source is, but Colombia is the second in in the whole continent displacement, only after Mexico, considering population going out of the country, and most of that is driven by these conflicts too, or the lack of socio-economical opportunity, jobs, but it's mostly a social issue. So second after Mexico, if you see what's happening in Mexico now, then you can consider how Colombia is.
So thank you very much. This is a great project. I think the videos you showed suggested to me that maybe an intervention that might reduce hypertension could be to put in traffic signals or it looked like there were a lot of infrastructure issues that could address not only hypertension but other health issues, diabetes and things related to that. And I wondered whether your coalition had a link with people in the government who provide city services, or just perhaps because hypertension itself isn't a big priority, perhaps there could be an expansion of the health consequences, reduction of traffic fatalities or injuries and things like that. So I know it's a broad question, but it struck me that maybe as your group moves forward, that those would be people you would want to engage in the dialogue about.
In the coalition is involved the local Department of Health. Also at the beginning was involved the Department of Sport and Recreation. But if the Department of Health has 5 people in the staff, then the Department of Recreation has 2. So it's difficult to maintain the participation of these organizations. So that is one of the issues. But the problem is the resources. The city doesn't have enough resources for investing in traffic signals or traffic lights. So what happens is that the police is sometimes you see in the video is the only alternative to try to control the traffic. So because the level of taxes the city receives is very low because the socio-economic characteristics of the population. And one of the, for example, in the qualitative study, one of the comments from the participants was that the national government sent not the amount of resources that the city receives from the national government is very limited for addressing all of these problems. So it's like something that is it's a cycle.
Vicious cycle,
It's
right.
like a cycle. So it's very complicated.
Diego,
I
have
guess-
you?
Do you have a class
Yeah.
leader? Okay.
How much time do you need?
Was there can we do one final question? One final question and then we should.
My question
take
is, have you tried to start to put these results in the central government in order to have some participation from them in the intervention?
Yeah, what is one of the goals we have is to try to involve the national government. But I think that first, before working about, we need to try to discuss about social determinants of health first, because the idea of the idea of in the top person in the national government is that this is a biological problem, or that social determinants are not so important in explaining that situation in cities like Quito. So that is, I think, we need to set a national dialogue about social determinants of hypertension first, and then try to involve them in particular for the case of Quito.
And involve the transnational corporations that get all the riches from that very rich area, but unfortunately is discriminated because traditionally it's native peoples or African descendant people.
Yeah.
Especially the frame of TPP, the new agreement, what is it called? I'm sorry, the new trade agreement, Pacific Trade Agreement.
Just to say something, the stadium of the baseball in New York, the Yankees, was built with resources from Quito. Was a donation of the mining that was working in Quito, and they donate, this company donate the money for building the stadium, the Yankees stadium.
But not for the soccer. Wow.
Thank you.
Thank you so much.
¿Vas a estudiar ya?
I'm sorry.
Yeah, like community grassroots, like if
But you can have that education and see it.
My name is Luis Paez. Luis Paez, I'm from Colombia. Sorry.
De la graduación y ahora.
Anyway, thank you very much for having this. ¿Qué haces? ¿verdad? Ya.
Yo estoy con Marí
Ajá.
y hago contaminación ambiental y embarazo.
Muchas gracias.
Investigación.